Hello everyone, welcome. Today our topic of discussion is hypokalemia and hyperkalemia. Potassium is most abundant intracellular cation. The amount of potassium in the adult body is about 45 millimole per kg body weight. It is about 120 gram for 70 kg adult. 98% of the potassium found intracellularly and 2% of the potassium found extracellular fluid. Potassium has a strong relationship with sodium. Sodium is a main regulator of extracellular fluid volume, including plasma volume. Serum potassium reference range is 3.5 to 5.5 milliequivalent per liter. This is the microanatomy of the kidney. Here you can see the Baumel capsule, which is forming the glomerulus. Potassium is freely filtered at a glomerulus in the kidney and then passes through the different structure of the kidney like proximal convoluted tubule, loop of Henle, distal collecting tubules and collecting duct. In the proximal convoluted tubule, by paracellular mechanism, 65% of total filtered potassium is reabsorbed. In the loop of Henle, through a sodium, potassium and chloride pump, 20% of total filtered potassium is reabsorbed. This pump is inhibited by loop diuretics. In distal collecting tubules and collecting duct, hydrogen potassium ATPase pump is responsible for potassium reabsorption. Potassium secretion occurs mainly in the distal collecting tubule and collecting duct. Now let's learn the external regulatory mechanism. Acid-base balance can affect the balance between the cellular and extracellular potassium concentration. Acidosis increases plasma concentration of potassium by inducing shift of potassium from cellular to extracellular compartment in exchange of hydrogen. Insulin is important in preventing the large change in the extracellular fluid potassium concentration as it increases the potassium influx into the liver and muscle cells by stimulating sodium potassium ATPase pump. Catecholamine including adrenaline, noradrenaline, dopamine binding to beta 2 receptors on muscle cells stimulate sodium potassium ATPase pump causes increase of potassium shift into the cell. So here we can see the acidosis leads to efflux of potassium from the cell and insulin and catecholamine induces influx of potassium into the cell. Potassium concentration. Serum potassium reference range is 3.5 to 5.5 milliequivalent per liter. Hypokalemia is when level is less than 3.5. Mild hypokalemia is when the level is between 3 to 3.4. Moderate is when the level is between 2.5 to 3. And severe hypokalemia is when the level decreases below 2.5. Hyperkalemia means the level increases more than 5.5. Mild hyperkalemia is level between 5.5 to 6.5. Moderate is 6.5 to 7.5 and severe hyperkalemia is when the level increases above 7.5. Now let's see the symptoms of hypokalemia and hyperkalemia. Symptoms of hypokalemia are muscle cramps, weakness, fatigue, paralysis, constipation, respiratory failure, irregular heartbeat, also called arrhythmia. Symptoms of hyperkalemia are muscle weakness, numbness, abdominal pain, nausea or vomiting, diarrhea, chest pain, arrhythmia. These all are the symptoms of hyperkalemia. Let's see the mnemonic for hypokalemia. It is CRAP WFM. C for constipation, R for respiratory failure, A for arrhythmia, P for paralysis, W for weakness, F for fatigue and M for muscle cramps. Let's see the mnemonic for hyperkalemia. It is Candyman. C for chest pain, A for arrhythmia, N for nausea or vomiting, DI for diarrhea, M for muscle weakness, A for abdominal pain, and N for numbness. Now let's learn the ECG changes when severe hypokalemia or hyperkalemia occurs. In the hypokalemia, the changes are prolonged PR interval, peak P wave, ST depression, shallow T wave, and prominent U wave. In hyperkalemia, prolonged PR interval, wide and flat P wave, wide QRS complex, ST depression, and tall and peak T wave. Let's see the causes of hypokalemia. First is decreased potassium intake. Second is transcellular shifts of potassium due to insulin, beta 2 agonist, or thyrotoxicosis. Third is increased potassium loss, either skin, gastrointestinal, or renal loss, which occurs in diarrhea, Cushing syndrome, primary hyperaldosteronism, Bartter syndrome, Gitelman syndrome, Liddle syndrome, Fanconi syndrome, hypomagnesemia. Fourth is hypokalemia due to drugs like thiazide, loop, and osmotic diuretics, amphotericin B, laxative, theophylline, penicillin in high dose. Management of hypokalemia. Hypokalemia is more prevalent than hyperkalemia and most cases are mild. The goal of therapy for hypokalemia is to prevent and treat life-threatening complications and replace the potassium deficit and to diagnose underlying cause. Mild and moderate hypokalemia is typically treated with oral potassium supplements. Providing potassium 60 to 80 millimole per day in divided doses over days to week is usually sufficient. It should be taken with plenty of fluids and food. Potassium chloride is a preferred formulation for replacement therapy in most cases. Increasing dietary potassium is usually not adequate to treat hypokalemia. IV potassium chloride of 40 millimole in 1 liter of 0.9% NaCl is used in severe hypokalemia. Now let's learn about hyperkalemia. The causes of hyperkalemia are: first is excessive intake. In the patient with impaired renal function, especially GFR, when less than 15 ml per minute, a slight increase in potassium intake can cause severe hyperkalemia. Second is impaired elimination of potassium. It is due to renal insufficiency, either acute or chronic. Medications interfering with our urinary potassium excretion. Hypoaldosteronism. Pseudo-hypoaldosteronism, which refers to heterogeneous group of disorders of electrolyte metabolism characterized by hyperkalemia, metabolic acidosis, and normal GFR. Type 4 renal tubular acidosis, congenital adrenal hyperplasia, congestive heart failure, and constipation. These all are the causes of impaired elimination of potassium, which leads to hyperkalemia. Third is increased shift of potassium from intracellular to extracellular compartment. First is acidosis. Second is diabetes mellitus. Third is increased osmolarity to hyperglycemia or mannitol infusion. Fourth is acute cell tissue breakdown. Fifth is digoxin, beta blockers, and succinyl-choline like drugs. Sixth is hyperkalemic periodic paralysis. It occurs due to mutation of muscular sodium channel, resulting in paralytic episode associated with elevated potassium levels. This picture shows flowchart of differential diagnosis of hyperkalemia. If potassium level is more than 5.5 milliequivalent per liter, then check that it is true or fictitious. Sometimes, due to hemolysis of the sample, fictitious hyperkalemia can occur. Once you find that the hyperkalemia is true, then check for GFR level. If GFR is less than 15 ml per minute, then there are two possibilities. First is decrease renal potassium excretion and second is increase potassium load. In decreased renal potassium excretion, the causes are acute renal failure, chronic renal failure, and drugs. The causes of increased potassium load are supplementation, oral or IV potassium, potassium-rich diet, blood transfusion, and tumor lysis or hemolysis. If GFR is more than 15 ml per minute, then check for aldosterone level. If aldosterone is low, then check for renin level. If renin is low, then causes are interstitial nephritis, obstructive uropathies, drugs, diabetic nephropathy. If renin level is normal or high, then causes are primary hypoaldosteronism, congenital adrenal hyperplasia, drugs, additions or congenital adrenal hypoplasia. If aldosterone level is high, then the causes are post-renal transplant, obstructive uropathy, sickle cell nephropathy, drugs, PHA type 1, type 2 and type 1 RTA. Let's see what are the laboratory investigations required for hyperkalemia. They are electrolytes, CBC, blood gas analysis, serum osmolality, creatinine, urea, creatine kinase, ALT, LDH, glucose, HbA1c, renin, angiotensin, aldosterone. Urinary tests required are urinary potassium, sodium, creatinine, albumin. Another calculation required is TTKG, known as transtubular potassium gradient. Calculation for TTKG is serum osmolality into urine potassium upon urine osmolality into serum potassium. If TTKG value is less than 6, then it shows hyperkalemia due to renal causes. But if TTKG value is more than 6, then it shows hyperkalemia due to extrarenal causes. Management of hyperkalemia. Stop all drugs that might cause or aggravate hyperkalemia. The treatment regimen include dextrose insulin infusion, beta agonist like salbutamol, sodium bicarbonate, loop diuretics like furosemide, ion exchange resin, renal replacement therapy, hemodialysis, continuous veno-venous hemofiltration. Important point from this video is the reference range of potassium is 3.5 to 5.5 milliequivalent per liter. Critical hypokalemia occurs when level drops below 2.5 milliequivalent per liter. Critical hyperkalemia occurs when potassium level rises more than 6 milliequivalent per liter. This is in short about hypokalemia and hyperkalemia. Hope you like it, and these are the references for this video. Bye. Thank you. See you in the next video.